Hey guys, welcome to another episode of Health Matters with yours truly, Danielle Linane. Today I sit down with Dr. Fritz Jean-Pierre, a bariatric surgeon here at Wellstar. Dr. JP was kind enough to call in and share his knowledge while traveling. If you're ready to get the skinny on weight loss surgery, grab a pen and listen in. Okay, guys, today we have Dr. Jean-Pierre. He is our medical director over bariatric surgery or medicine, doc?
Surgery,
bariatric surgery for Wellstar Health System. He is also so incredibly generous that he is Skyping in with us. You're in St. Simons, right?
Yes, the American College of Surgeons is having their annual Georgia chapter meeting here in St. Simon. So it's not like I'm just out at the beach enjoying myself. I'm actually learning and trying to become a better, smarter doctor.
Well, that's why everybody loves you. But seriously, thank you again for taking the time out to speak to our listeners. So let's kind of jump right in. And if you don't mind doing us a favor, tell us a little bit about you. Tell us about your journey and, your training. How did you come to be at Wellstar?
Sure. So I'd have to be completely honest, it was somewhat of an accident. My wife is also a physician, and when I completed my training in general surgery a little bit before she completed her pediatric training, we were trying to figure out where we were going to move, what part of the country we were going to live. And being a woman from Jamaica, she couldn't take that cold weather in Chicago anymore, so we knew we had to head south. And we looked for fellowship options. We're in a city that we both can get to and we really enjoyed. And Atlanta was one of the ones that stood out to us. So we both applied to fellowships here in Atlanta. She started actually before me. And then I came afterwards and I joined the bariatric fellowship program at Morehouse School of Medicine. And it was a great experience because it was not only a minimally invasive surgical program, but it really was a very high volume bariatric practice as well.
Right.
And it gave me my first real hands-on exposure to bariatric surgery. And made me realize that this was the career that seemed perfect for me because it sort of integrated the wonderful technical aspects of surgery with the more touchy-feely patient success stories you see in a medical practice.
Absolutely.
So I think it was in 2012, after doing my training and being in private practice for a little while, I got a solicitation for a job out in Marietta at Wellstar Hospital, and I came out and joined a senior surgeon that was there at the time. And the two of us started trying to expand access to care for the folks in the Cobb County, Marietta area.
I love that. I actually remember that. I remember when you were new.
Yeah.
That was when we were both back in the OR. So where'd you go to school?
I did my went to University of Florida, go Gators, woohoo, for undergrad.
That's where we're not friends. That's all right.
But I went to medical school in Chicago at the school. Now the name is different. It's called Rosalind Franklin University. At the time, it was just called the Chicago Medical School. And then I did my surgical training in Chicago at the University of Illinois at Chicago Mount Sinai program, the general surgery program. I did a year of research, and then I wasn't quite sure if I was going to do a fellowship or not, but when I got closer to the completion of my general surgery training, I knew I wanted to get a little bit more specialization.
Right.
And that's when I did my fellowship over here in Atlanta at Morehouse School of Medicine.
It's awesome. It's awesome. And just a little sidebar, guys, Dr. Jean-Pierre is a wonderful physician, but even better, he's awesome to work with and for. I had the pleasure of, it's the truth, I had the pleasure of working with him both in the operating room and in the clinic, and just a wonderful surgeon. His patients love him. His staff loves him. It's really kind of hard to find somebody that doesn't like Dr. Jean-Pierre. But I just wanted to kind of throw that in, that you are just such a joy to work with, and I'm glad to be able to work with you in this capacity as well. So what I want to talk about now is the obesity epidemic in this country. It appears as though, which seems kind of contradictory with the billion-dollar fitness industry and wellness industry that this country has, that it seems the obesity epidemic is growing and it's getting worse. What are your thoughts on it as well, and why we consider it a chronic disease now?
Yeah, great question. So you are 100% correct. Obesity is in fact truly an epidemic, and Reason why we say that is because it affects more than a third of the U.S. population. It's actually over 35% now. And in Georgia, and specifically, it's about 31% of our residents of the state of Georgia suffer from obesity. So we know that it's increasing at rates far more than we knew or we could ever imagine. The rate of obesity just from 2007, 2008, when I just was finishing my surgery training and getting into this field, to 2015 and 2016, the rate of obesity has increased from 33% to 39%. So it's getting more and more prevalent. We're seeing more and more cases of it. Now, as far as the physiology behind it, why are we seeing that? We don't entirely have all those answers.
Right.
But it's been extremely helpful, I think, in just being able to make that diagnosis. And in 2013, the American Medical Association recognized obesity as a chronic disease state. So we know that it's not just an issue of people who are not able to stop eating, which is a horrible, horrible misconception.
Yes, it is.
I think a lot of people, and to be honest with you, healthcare providers are also guilty of this. There's definitely a negative bias when it comes to obesity, and we don't recognize that there are several metabolic and hormonal and psychosocial reasons why people struggle with obesity.
Isn't genetics one of them too?
And genetics, exactly. There's so many different reasons behind it. So it's an interesting field to be in, and I think that with the increasing complexity and the increasing number of people who are suffering from the disease, it makes me real excited to be part of the team of healthcare providers who can hopefully provide some solutions for all these people who are struggling with obesity.
You're so right too. Now, you mentioned that the AMA back in 2013, kind of labeled it a chronic disease. Why did they move? Is it because of all the things you said? Because it's not so much about what you're eating and not moving. Is it because of that and all the other comorbidities that come along with it? Talk a little bit about that.
Sure. Yeah. So obesity is very closely tied to lots of different medical conditions. The most common ones that we always hear about are type 2 diabetes and high blood pressure, high cholesterol, sleep apnea. There's some that are not so well understood or not well reported, I should say, or that a lot of people may not be aware of. Like, for example, polycystic ovarian syndrome.
Right.
Women who are having trouble conceiving and having irregular menstrual cycles, it may be, in fact, related to their obesity or their state of obesity. That's making their disease processes a little bit harder to manage. There are over 13 cancer types that have been linked to obesity, including esophageal and breast and endometrial cancers. And I think that because of how society looks at people who have obesity, they don't get the same type of access to care or recognition that their condition is not entirely their fault.
Right.
And that's, a goal of mine is to continue to expand some of that, that knowledge base so that people understand that, look, it's more than what you may think, and these people really need some help.
Absolutely. So let's talk a little bit about your work then when you mentioned, future goals of yours. So talk a little bit about bariatric surgery. And I mean, just the very simple question is, what is bariatric surgery?
Yeah, so bariatric surgery is essentially metabolic and restrictive types of operations that we perform on a person's digestive system. What we know now is that the digestive system is far more complex in the regulation of your body's metabolism.
Right.
The example I give is like a thermostat in your AC. When you are struggling with obesity and you've accumulated a large amounts of body fat, your physiology, the way your metabolism works, changes. It's very hard for those type of patients to lose the 10, 15, 20 pounds that someone of normal weight may be able to do very easily just by putting down the pasta or exercising a little bit more.
Right.
What we see in the obese patient population is that when they start to exercise or they start to reduce their calorie intake, their metabolism actually works against them. It slows further. So their metabolism gets down, gets even more slow.
Right.
And a lot of the hunger signals and starvation signals are activated, which can lead to cravings and the desire to eat more. And with a slower, lower metabolism, even a little bit of food that they're eating. So we have patients who are on very low calorie diets, less than 1,000 calories a day, and they're able to put on significant weight because their metabolism is running so slowly. So bariatric surgery is interesting because I tell folks it's like a plumber coming to your house and working on your kitchen sink. And when he leaves, all of a sudden your Wi-Fi is better. You're like, wow, that's a great plumber, right? So that's what I like to sort of make that analogy all the time. I use that same joke with all my patients, so I can't use it again anymore. But
that's so good.
That's basically my job, is to go in there and change the plumbing and see if I can create some Wi-Fi changes. Make
Absolutely.
it so that your metabolism is okay with you consuming less calories without giving you the presumption that you're stranded on a deserted island and that all of your starvation signals need to be activated. Help to increase the way your metabolism works and make it run more efficiently, as opposed to slowing your metabolism down, like we see sometimes with traditional diet and exercise programs.
So can you give an example just real quick? You had mentioned, those folks who do have below 1,000 calorie diet. What is a normal caloric intake for a normal healthy weight individual?
So that's the part that it differs for everybody. So you can be maybe 20 pounds overweight and you can consume 3,000, 4,000 calories a day, and you might still be able to lose weight depending on your genetics, depending on your way your metabolism works, your physical activity, the amount of calories that you're actually burning throughout the day. Right. Whereas an obese patient may consume less calories and may not be as physically active due to some of their obesity-related conditions like osteoarthritis and fibromyalgia, chronic joint pain, and that even though they're consuming less calories, their metabolism runs slower, so therefore they gain weight in that scenario.
And I was fishing for that answer, which I'm sure you probably knew that, because one of the things that we see a lot is, 1,200 calorie diet, or, it's all of these, you should be eating this, but what I love is the real answer is, well, everybody's different. So
right. And that perception again that, hey, it's all about calories in versus calories out is not always true, because a lot of people, like I said, consume less calories than I do, and they're unable to lose weight. Well, I'm not probably in that category myself too, because I'm not so successful at losing weight myself. But there are some people who can lose weight a whole lot easier just by reducing their calories throughout the day. Absolutely. So it is definitely more about the internal engine of the body. Your metabolism determines how your body utilizes those calories, and if it's for some people it stores it, for other people it burns it. So you can't always just look at the number of calories in versus the calories out.
Absolutely. So within bariatric surgery now, you do 3 procedures, correct?
Yes.
Okay.
Yes. So there are more than 3 procedures available, but currently what we're seeing throughout the United States and actually throughout the entire world are 3 procedures are the predominant procedures that are being performed and that are giving us those metabolic changes that we were just discussing. The sleeve gastrectomy by far is the most popular operation now. About in 2017, about 60% of the procedures that were performed in the United States were sleeve gastrectomies. Second to that would be the gastric bypass, or the Roux-en-Y. This has been, or RNY. It's an operation that's been around for a very long time, and still has excellent results, and can actually be more suitable for certain patient types. Excuse me. So some patients who have really brittle diabetes, who struggle with their diabetes control, will actually see better remission in their diabetes with the gastric bypass than you could see with the sleeve gastrectomy, for example. Now, people who struggle with heartburn and reflux disease may not be the great candidate for sleeve gastrectomy, because we're tending to see a little bit more what we call de novo reflux, or basically new reflux that the surgeon gave you. Right. I'm not in the business of giving you problems. I'm trying to fix your problems. So that's another, difference between some of those operation choices. At Kennestone, we have a pretty large patient population that also are good candidates for what we have, an operation called the biliopancreatic diversion and duodenal switch, or the DS. That's a great, really, really strong, powerful operation, but it does have significant changes to your plumbing and to your Wi-Fi, meaning that it can create changes in your bowel habits. I have patients who say, Doc, I'm doing great with my weight loss, but I tell you, when I pass gas, I can clear a room. I'm like, hey, that's sort of what we signed up for. It's the nature of that operation. You're going to have more frequent bowel movements. You're going to have very foul-smelling gas. They have to have a much more strict vitamin and nutritional supplementation regimen than even the sleeve gastrectomy patients. Gastric bypasses are somewhere in between there. So when we look at the overall numbers of what's being performed, we're seeing more and more patients who have had previous bariatric procedures who are also requiring revisions. So someone who may have had a lap band in 2005 is experiencing weight regain. And it's sort of the nature and the expected chronicity of obesity is that they're going to have a need for multiple interventions in their lifetime. But that's where access to care is still limited. We need to do a better job of letting insurance companies and providers know that this is not unusual and this is sort of the normal progression of obesity.
Well, it's kind of the same, just to maybe give the listeners an apples to apples comparison, sort of, maybe like an apples to like a smaller apple.
Yeah, I got a great one actually. So think about this. You are going up the flight of stairs, not me, but let's say an older gentleman, a 55-year-old gentleman is going up the stairs, running up to go grab his phone because he hears it ringing, and all of a sudden you have this terrible tight chest pain. You know, the immediate response is, oh my God, I'm having a heart attack. So his wife rushes him to the emergency department. What do? They're going to look at his risk factors, and they're going to recommend several different interventions.
Correct.
The first one may be, hey, you know, you're at risk for coronary artery disease. You may have had a heart attack. We need to do some lifestyle modification. Reduce your salt intake. You need to, increase your physical activity, lose some weight. Or they may say, you know what, you actually need an angiogram, but we need to go ahead and see what's going on. You may need a stent in your coronary arteries.
Right.
Or in the worst case scenario, they may need surgery.
Right.
But you never get that scenario where you walk into the emergency department and the ER doctor says, or the cardiologist says, hey, you only get one option. What is it going to be? You're going to lose the weight, or you're going to get this stent, or you're going to have surgery, and that's all I can do for you.
Right.
Obesity is not treated that way.
Right.
We see patients and we say, well, you have one option. You can have this one surgery now, and you can never have anything else. Or if you've had surgery, people assume that you're not a candidate for some of the really good pharmacologic obesity medications that are available now.
Right.
We recognize that this is not the right way to treat obesity. It's unfair. It's biased. These patients should have the same access like that patient who had that heart, the heart disease. If intervention A didn't work, you should be able to come back and get intervention B. You may need intervention A and B. That's part of the complexity of the disease, and we need to treat it with all of the resources we have available to us.
That's perfect comparison there. I like that. So can you tell us too, what is like your average weight loss percentage per operation that you do?
Sure. So that's another interesting point. It does vary.
Yes.
I'm a very, very strong advocate of one size does not fit all.
No.
Because we'll see that, patients come in and say, well, my sister had the lap band and she's done great. I think I need a lap band too. I'm like, well, you're 10 years older than your sister. You came in on a scooter, so you're not as mobile as your sister was.
Right.
And, you have diabetes. She didn't. There's different reasons why different operations may be successful. But the way that we measure it is what we call a percentage of your excess body weight or excess weight loss. So the example I give is, let's say you're 300 pounds. And to make the math easy, because I'm not great at math, you're supposed to be 200 pounds. That means you have about 100 pounds of excess weight.
Right.
With a sleeve gastrectomy, what we see on average is that most patients will lose about 60 to 70% of the extra weight that they're carrying. So in this case, they would lose 60 or 70 pounds. That means they're not going to be all the way down to 200 pounds. They may be 230. They may be 240. But they're still significantly healthier, and they have an improvement in their metabolism, and they're able to maintain that weight loss. It's about creating a sustainable change with that weight loss. With a gastric bypass, the weight loss is a little bit better because we're now adding what we call malabsorption. They don't absorb 100% of the nutrients and also some of the bad things, the calories, the fats in their diet. So those patients tend to lose a little bit more. It can be as much as 80%. So the same example, they'd lose 80 pounds and they'd get down to 220. So they're getting closer to their ideal body weight of 200 pounds, but they're still not there.
Right.
With the duodenal switch, that's the strongest, biggest operation we have. They can lose up to 90% of their excess body weight. So those patients would lose 90 pounds and get really close to only 10 pounds over their ideal body weight. But yes, they would have to take far more vitamins. They would have to make sure they're okay with the changes in their bowel habits. It's a complex operation, but in our hands, we've had really good success without any major complications.
Absolutely.
Or very minimal complications, I should say.
So I know the next question that's going to be on a lot of people's brains is, okay, so that 60 to 70 or that 80 or that 90, it's not 100. So what do we do? How do we get to the rest of the percent? How do we get that last 10%? How do we get that last 20?
You may never get there. And I tell that's a really great question, Danielle. And I tell you, I feel like unfortunately people have that misconception that you have to be 200 pounds. You may not have to be 200 pounds to get you off your diabetes medications. If we got you to 240 and you're able to come off your diabetes medications, then that's a win.
Right.
And I tell patients that the surgery itself is not going to get you to the 240 or the 220 or the 210. You're still going to have to do all the right things. So part of this process when it comes to changing, getting that sustainable change again, to give you the sustainable results, is that you have to change the foods that you're eating. You do have to change the physical activity you're doing. But now you have the immense hormonal and metabolic improvements with the surgery that make it a lot easier for you to keep that weight off.
Yeah.
You have this sort of boost that you didn't have when you were trying to do it on your own and your body was working against you.
So you just.
But that being said, it's I never tell my patients, hey, I'm going to guarantee I'm going to get you down to 200 pounds and get you to 100% of your excess weight loss.
Right.
It's extremely hard to take someone who is morbidly obese and get them all the way down to what's considered their ideal body weight.
So you just kind of siloed me into my next question. So bariatric surgery is not a quick fix.
Not at all.
Not at all.
Matter of fact, if anybody, gives my patients a hard time, I threaten them. I say, look, my patients are the hardest working folks you'll ever see because they really have to do a lot to prepare themselves. A lot of insurance companies will have these requirements of participation in a physician supervised weight loss program. For me, I understand what it is. I'm not saying I'm trying to find the politically correct answer. I'm not saying it's about the time. I don't think you necessarily have to do 6 months, 3 months, but I do think you should have some guidelines. Every good bariatric program should have some guidelines. We want to make sure that patients have a good understanding, have good background in education, and they're able to practice those good habits before surgery. It's just like training for a marathon. You can't expect to go out tomorrow and all of a sudden run a marathon if you haven't been running at all. So we want you to start practicing doing those things before surgery.
So talk a little bit about those. Like what are some of the things? So mainly you've got a comprehensive team there. So
yes.
Talk a little bit about your team.
Our program is so successful, not because of me, but I think because of our team.
So much.
And it started with you back then. I'll have to admit, without you're laying down the foundation with our exercise physiology program, that's a big part of it. So we recognize the type of exercise that you do is also important. People get the assumption that weight loss is tied very closely to just that, aerobic exercise. Mm-hmm. You're out there, you're on the treadmill for 2 hours, you did a great job. It is good that you are moving and you're being more physically active, but the reality is that resistive exercise is a big part of it as well. Mm-hmm. Being just active in the non-exercise way is a very important part of it too. A lot of times we get that we're just much more sedentary in our lifestyle. So sure, you may go to the gym and spend half an hour and do a great job, but if you're sitting at your desk for 10 hours in the day and you're not moving, your overall energy expenditures are not going to be as high as we'd like them. So we try to encourage folks to stand as they're doing their conference call, fidget in your seat as you're sitting there,
right.
Park your car a little further away so that the normal sort of activities that you're doing that are not exercise per se are still more active than what we're doing at rest. Yep. But resistive exercise is thought to be muscle preserving. Mm-hmm. So being able to ensure that as you're, especially after surgery with bariatric surgery, you could potentially lose muscle. We want to do whatever we can to maintain your muscle mass and preserve that. So resistive exercise is very instrumental in that.
It's huge.
We also have a great bariatric psychologist, Dr. Tanette Robinson, that works in our office, and she really likes to delve into some of those psychological issues that a lot of our patients experience. Misconceptions, again, are that all bariatric people or people who struggle with obesity must be stress eaters or they must be, eating out of depression. No, a lot of my patients say, Doc, I just love food. I eat when I'm happy. I eat when I'm bored. I don't have to be sad.
Right.
So it's not always just the bad things, but understanding how, in order to be successful, you're going to have to make some changes and see how you can start implementing those changes. If you've had a stressful day, go home and, organize some file cabinets, do something different, get your mind off of food. Don't just go home and grab something easy to eat.
Right.
If you're having a good day, go for a walk, reward yourself. It doesn't say that you can't do a little exercise to reward yourself. You kill two birds with one stone.
Right.
Those are sort of the things that we always try to address. And of course, nutrition is a huge part of it as well. So understanding what nutritious, healthy food looks like, I'm at this conference now and I picked up a great little tip that I have to share with you. They call it the 3 S's. What happens to a lot of folks is that they skip their meals, which leads to starving and then leads to stuffing.
Yes.
When I heard that, I was like, I'm writing that one. I'm stealing that one. That's a great one. We don't want you to skip meals. We don't want you to starve yourself because you are going to end up stuffing yourself. And that's not a good way to to provide your body with the nutrients it needs and provide your body with the fuel it needs to be metabolically as efficient as we need it to be to lose weight. So we do concentrate on higher protein, lower carbohydrate, low fat fuel sources, food sources, basically. But it doesn't mean that you can never enjoy dessert. It just means that you have to do it in moderation.
Right.
So if you're going to go for that pastry, split it with your wife. You don't have to eat the entire pastry yourself. But that's after you've had your grilled chicken and your spinach. Now you're having a little piece of pastry for dessert. No big deal. That's not going to completely disrupt your weight loss goals or your journeys.
Fill up on the good stuff. Fill up on the good stuff.
Right. Fill up on the good stuff first, and then you can have a bite or two of the bad stuff, and that's not going to rock the boat too much.
I got it. Thank you so those are all in your office, correct? You have a registered dietitian, an exercise physiologist, and Dr. Robinson, correct?
Yes, exactly. So
That's
we try
awesome.
to give you that whole one-stop shop where you can come in one place and feel, supported in a non-judgmental place where people understand exactly what you're going through, and we're here to help you with all the different avenues that we have available.
I love it. So my last kind of point with you is if anybody's thinking, maybe I want to have surgery, or obesity runs in my family, or, metabolic disease runs in my family, what are some preventative measures that you would recommend that people, kind of either jump ahead, or if they want to start preparing for surgery, what are some things that you could recommend that they could do on their own that's just easy things?
One of the earliest things you can do is just get educated about it. You don't have to be the smartest person to understand that this is bigger than you.
Right.
This is not something that you're going to be able to tackle on your own. So some people get really down on themselves because they feel like they have to do it all on their own.
Right.
There are resources out there. There are tons and tons of websites that provide really great information when it comes to obesity. There's, our Society for Bariatric Surgery is called the ASMBS. The American Society of Metabolic and ASMBS. I said yes, American Society of Metabolic and Bariatric Surgeons. The Obesity Society is another place where you can go get some tips for patients. Having that discussion with your primary care doctor or your cardiologist or your pulmonologist about options to help with weight loss. And then what I would say, obviously, the call to action for me would be give us a call. Come visit our office. We are going to find a way to help you one way or the other. If you're not a candidate for surgery for some reason or another, we have great other practicing physicians right here in the Wellstar system that we can refer you to. Really strong non-surgical weight loss programs. They have the similar comprehensive approach that we have in our surgical practice. If you are a surgical candidate, it doesn't mean that just because you came to the consultation that we're going to have surgery either. We may, it's going to be a learning process for you and for us to get to know you. So we want to make sure that you're getting all that education before you come in. So just getting more informed is what I'd say is your first thing to do.
Awesome. Now, how can our listeners, if they want to call your office or schedule an appointment, what's the best way for them to find your information? I mean, a Google search, obviously, but.
Yeah, so we are Wellstar Comprehensive Bariatric Services at Kennestone Hospital in Marietta, Georgia. Our office number is 770-919-7050. Again, 770-919-7050. We have a brand new website that should be launching in the next few weeks. That's going to be spectacular. It's going to have lots of patient testimonials, lots of resources and information on there, an online seminar that you can watch and sort of see a little bit about the program and what you would need to get yourself ready for surgery. So that would be your first step, is call the office and we'll send you out a packet, some information for you to fill out. And if you're qualified, we can have you come on in for an appointment.
And guys, I'll link that, the URL to their website. I'll link that up in the show notes for you, so you guys can just go straight down and click on that and go straight to the website for what he's talking about. And then you are also on the Wellstar website, correct?
We are. I believe the Wellstar address is just wellstar.bariatrics.org.
Okay.
There are, I think, a total of 4 programs now in the Wellstar system. We have the Kennestone program. We have a program at Atlanta Medical Center. We have another program at West Georgia in LaGrange. And the newest program is over at Cobb. They're just starting that one off in the last year or so. So we're trying to increase access for patients. And as a person who's in this field, I feel obviously very passionate about it. But I think that as an organization, I think Wellstar really has proven that they're trying to do everything they can to increase access for patients so that they can have an opportunity to come in and have a discussion about how they can improve their health with some weight loss.
Absolutely. Dr. JP, again, thank you so much for joining us. This has been absolutely amazing.
Thank you. Thank you for having me. I really appreciate it.
Yeah. All right. And guys, again, all the information that he said in the, just now about how to contact him, the website, I'm going to link all of that up in the show notes so that you can just follow the information there. And if you do have any questions specifically for Dr. JP or anything else regarding metabolic surgery, feel free to email me, health365@wellstar.org, and I can get those questions to the right people. Dr. JP, enjoy the rest of your time in St. Simons.
Thank you. Thank you so much. Appreciate it.
All right. Thanks.